Hi, everyone. Good evening. We'll get started in just a moment. We'll let everyone make their way into the room. I know we've got a lot of people signed up tonight. This is going to be my favorite one. Dr. McGee, I think this is probably like our 10th time together. So
Love it.
I absolutely love it. I always love when we're paired up because this is my favorite topic, and I love the way that you present and engage. And I know that there's going to be a lot of people joining us. So, with that being said, I'm going to get started as people make their way in. Just some housekeeping before we start. So, welcome to tonight's Wu University event, Building a Dry Eye Center with Dr. Selina McGee.
Perfect.
I am your host, Dr. Jennifer Stewart. So it's my great pleasure to once again welcome Wu Yu favorite. Dr. Selina McGee is the visionary founder and owner of Bespoke Vision, a private practice that offers patients a wide range of optometric eye care via Dry Eye Center, specialty contact lens clinic, and aesthetic suite. She's a renowned national and international speaker, an adjunct assistant professor at the Northeastern State University College of Optometry. She's on faculty at the Oklahoma Medical Research Foundation and currently serves as president for the Intrepid Eye Society and secretary of the Board of Examiners in Oklahoma. She's a fellow of the American Academy of Optometry and a diplomate of the American Board of Optometry, and is the past president of the Oklahoma Association of Optometric Physicians and past trustee on the SECO board. She's the co-medical editor of Modern Optometry and associate editor of Presbyopia and the Aging Eye. She earned her Bachelor of Science in Biology, where she graduated summa cum laude, and Doctor of Optometry, also summa cum laude, from Northeastern State University, Oklahoma College of Optometry. With that, Dr. McGee, I will once again turn it over to you. We are so excited to have you back and can't wait for this presentation.
Yay. Thanks, Dr. Stewart. Appreciate it. There's all my financial disclosures before we get started. All of these have been mitigated as we go through here. So we are going to talk about the Advanced Dry Eye Clinic and how to build this and ask questions throughout. You guys know me. I like to keep it interactive as much as we can through this kind of platform. Thanks to Wu Yu for hosting me. I love to be here. You guys present the best CE, and it's just always a pleasure to work with you guys. So without further ado, let's jump into the Advanced Dry Eye Clinic, and we'll start off with, how I think differently and how we can start to build things together. And I'm always challenged with, I want to do everything like right now, and that is does not pan out. And so I'm going to kind of walk you through and give you some things to think about. And it doesn't matter what you're building, whether it's dry eye, whether it's specialty lenses, vision therapy, traumatic brain injury, whatever that is for you and what you're passionate about, these things can all apply. And you can take these core principles and then build them to your authenticity so that whatever you put together has the bones, but then it has your stamp on it. So when I think about what I wanted to create and what I wanted to build, the why message is really important because this is not easy, and building anything is not easy. And so when you're going through this, I think it is really important to have your North Star of what you're trying to achieve so that when things do get hard and you're being tasked with different things that you're like, nope, this is my North Star. It's easy to get distracted. And, I'm someone that likes shiny things. And so it's very easy to get distracted. And so having that North Star and these bones that we have that we're going to talk about are key to having a successful integration of your dry eye practice into your clinic. So this is my brand. And when I think about how I came to this name, it took about 6 months to 9 months just to come up with Bespoke. And I was very intentional about that because I wanted something that meant customized, and I wanted it to the patient. And I wanted to do that all within the title. And that's not easily done, right? And so everything that you do and you touch and the way that people feel, that is your brand. And all of those things encompass. And so it really deserves a lot of detail and a lot of thought, not just piece together a piece at a time, because then it can feel really disjointed and then it doesn't always make sense. So think about your why and your brand and what you're really trying to achieve, and then you can reverse engineer it from there. And so my brand is Bespoke Vision. Everything that I do is customized. And that's what that means to the patient. And my favorite thing about this is no one really knows what bespoke means. And that is an invitation for my patients to ask, well, what does the name of your practice mean? And then we get to tell their story. We exist because the things that we put into our clinic and the systems that we have in place take care of you. We're a high touch, high technology practice, and everything is customized to each and every patient. And that's just who we are and who our brand is. And so by saying that and doing that, I get to tell that, my team gets to tell that to each patient. And that patient walks away with a relationship guide of how this journey is going to go with us together. So that's my brand. You either have culture by design or by default. You have a culture. It's just whether you've intentionally put it together or it just exists because there's a million other things to do in the daytime. But these are the key pieces that I have built over the last 20 plus years. And it took me about 20 years to build it, honestly, of doing a lot of things wrong before I figured out exactly what I wanted and to do it in the correct way. And remember too, it's an evolution. So just because you're doing something today doesn't mean it's not going to evolve into something bigger tomorrow. So I just wanted to share that background with you guys. The people that you have in place to help you execute this, I cannot overstate how important this is because they're the ones that are doing all of the details and they're putting the systems in place so the wheels don't fall off as you're seeing patients and you're making decisions. And you can't do that in a vacuum. And it's really easy to go to a meeting or sit through a CE like this and get really excited and go, okay, great, I'm going to do this tomorrow. And I'm super pumped and have this really high energy. And you go into clinic and nothing's quite ready. And then you lose your momentum and it's really easy to get frustrated. And so I think it's just important to build that character skill of slowing down and doing things systematically and bringing your team along with you, because I have done it so wrong so many ways. That recipe works the best. And so the people that you put around you, that's super important. So that's where you make your first investment. People always ask me, how do you build a dry eye center? What equipment do I need? What diagnostic tools do I need? You need your people first. Your people and your slit lamp and your investment in this is what is going to carry you into those diagnostic pieces of equipment and the therapeutic pieces of equipment. But if you don't have that in place, it's going to be a struggle. So looking at my practice, these are all the things that we have. We see primary care patients. We do specialty lenses. We have a dry eye center. I do a lot of aesthetics. And then we still have a high-end optical. And these are all the pillars of our practice so that if something does change and something beyond our control, we lose a pillar, well, guess what? Our whole house of cards doesn't fall. And we're always looking for the next pillar, the next physician that's going to bring us traumatic brain injury or whatever it is that they're super passionate about. What can we offer our community that's currently not being offered, where we can really start to deliver bespoke care and a bespoke experience to patients that are seeking help with their vision? So your mindset, what is your why? And I touched on this earlier. You really have to understand what your core values are. How do they align with your goals? If you're in this to just, well, it looks good and it seems to make a lot of money because there's some therapeutic pieces of equipment that you can pay cash for, and you see all these like really sexy things happening, that's not going to go well, because when it gets really hard or things change in the reimbursement strategy, then I don't want that to be that's an end result. That's not your purpose. And so understanding that about yourself is important, cultivating that growth mindset, being able to compel that vision to the people around you so they can execute your vision, super important. And then staying focused and not distracted so that you can get to where you want to go. You have to have a culture that can handle change, because think about the dry eye space. In the last 20 years, we've gone from having 0 therapeutics to having 3 approved just last year. We now have multiple diagnostics, multiple devices that will also help us. And this just continues to grow. As we currently speak, there's 1, 2, 3, 4, there's 5 other things that are happening in the dry eye space. If those get approved, that will happen in the next 1 to 3 years. So you have to be open, and your team has to be able to handle change. Empowering your team, they have to be able to make decisions without you standing right there next to them, micromanaging them. And you have to invest in your growth. And you guys are doing that. I'm preaching to the choir right now because you're sitting here with me and we're going to do this together. So you're already like there because you're investing. You have to be able to lead a team, and you have to be able to clearly communicate what you want to have happen. And then you have to foster that collaborative network within your community, so that you guys can grow together and do this together. And you've got to have things in place like KPIs. How are we going to know if this is working? What does success look like? How are we going to measure this? Because if you don't talk about that on the front end, no one knows when they get there. And nothing is more frustrating for a team member than aiming in whatever direction we think we're going, and then it's aimed 180 degrees off from where we should be. So those are things that you have to constantly talk about and foster and think about. And, if you ask any team at any given moment, mine included, the number one thing that they think is lacking is always communication. And we're a practice that I meet with my leadership team on Mondays. We meet as an entire team on Tuesdays at lunch. We have department meetings weekly, and then we have one-on-ones with the people within the departments. And so we stay in constant communication. And even with that, the number one thing they're going to tell you is we don't communicate enough. So I share all of that because these are things that you have to think about to be able to execute these. This is the number one thing that gets in our way as a community of optometry. This is one of the things that I struggle with, and I bet a few of you probably also struggle with, is, man, I don't want to feel like I'm selling anything. And, it's uncomfortable if you feel like that. It comes through in your body language. It comes through in the way you present your ideas. And so it feels very salesy and not good. But if you swap and just think about swapping that word, like I feel like I'm selling a dry eye treatment. I feel like I'm selling the patient that they have an issue. If you just swap that word sell for help, that completely changes your mindset, and it completely changes your body language, because all you're doing is helping the patient. They don't have to do anything that you say. You get to educate, and you get to help that person with the knowledge to make the best decision possible in that moment in time. And if you can do that well, and each and every one of you can, if we get out of our own way. And I still get hung up on this sometimes, because in my head, I'm like, oh, this is out of pocket for the patient. Can they afford this? Should we try these 3 other things? Is it overwhelming to the patient? Well, no, it's probably just overwhelming to me, actually, in that moment. And so just that one piece can be really helpful. Connecting people to their pain. And this is why I think it's so important to have a standardized questionnaire with all of your patients. I use a speed questionnaire because I'm able to take those symptoms the patient's having, and then I connect it to what they're experiencing, because I have the solution that's going to help them with that. But if I don't set that up right and I don't connect that, there's a gap, and it feels uncomfortable for me and for them. So you have to get really good at asking questions and then connecting those things to the patient. And again, getting out of our own way. We're all guilty of this. This pain funnel comes directly, honestly, from a sales program that I went through. And this helps me in every facet of my practice, whether it is with patients, whether it's with my team members, whether it's our partnerships with our reps and companies that we work with who help us with our patients. All of these questions that you can dig into, and if you do a little bit of research around the pain funnel and being able to connect that, you will really take your practice to the next level. So begin with the end in mind. I love Stephen Covey's book from many years ago, The 7 Habits of Highly Effective People. And one of his facets is begin with the end in mind. I knew what I wanted to create. I wanted to create something really special where people wanted to come to work and it didn't feel like work, and patients were managed in a way they'd never experienced before. And I wanted to never see another dry eye patient think to themselves, well, I guess this is just how my eyes are going to feel for the rest of my life. There's nothing else that can help me. That is the one piece, that's my North Star, because where we are in time, there's so many things that I can help with a patient. There's so many things I can do with our younger generation to help prevent where some of my patients are today. It's why I sit here and have a lovely evening with you guys, because if I can share some things I've learned and now your patients can pay that forward, then we really have created something special. And so that's what I began with, this experience of something completely different. And then I reverse engineered it way back to where we started. We talked about measuring progress. Just make sure you have SMART goals. You have KPIs, key performance indicators that are leading you so that you're not doing things retroactively. You can see what's happening and go, we're not going to hit that goal. What's in the system that's making us not do that? Let's talk about it. Let's pull that out and look at it closer. Those are things to put in and systems to put in place so that when you start to do a lot of these things, then you have the system. You literally need a system for the how to. That's the gap. We all know the why. We know what we should do. It's always in the how that is a struggle for all of us. So here's a really nice mnemonic that I like to follow. And I learned this in the same little thing as my pain funnel. When I think about what I'm learning and when I learn something new, there's steps, and it's called ACASH, awareness first. So recognize the patient has dry eye symptoms. Go back to your clinics, put in the system of how am I going to uncover patients? That's all you're going to do. You're going to start right there. You're going to uncover symptoms. And then you're going to build your knowledge. Okay, I'm going to do these tests and I'm going to figure out why the patient's experiencing this. I'm going to build all of that knowledge. Those two things are pretty straightforward. We've been well trained on how to do that. And you notice there's a big line after number 2. Application is the hardest part. When you apply something new, it feels really uncomfortable. And you have that moment of conscious incompetence. And you know that you're not good at it. You hate it and you do it anyway. And that's when it becomes a skill. Because when it becomes a skill, okay, now you're actually like, you feel good. You know things, the muscle memory starts to kick in. And then before you know it, it's a habit. And you can't imagine practicing any way different than how you do now. But if you can make it past the application and that conscious incompetence, so eventually it becomes unconscious competence, that's where the magic lies. So hopefully I can help you do that tonight. So first things first, establish that baseline understanding of patient's dry eye symptoms. Put in that patient questionnaire. We'll talk about that. And then start to look at, okay, what objective tests am I going to utilize in my clinic today? What am I going to use tomorrow? And then how is this going to evolve over time? Understanding the etiology and then understanding the tools that we have for aqueous deficient patients, for evaporative patients. And guess what? Most patients have both. So when should we test for dry eye disease? We should be testing every single patient that is coming through the doors. So every primary care patient should have a questionnaire, in my opinion, because what we now know is 40% of people in their 40s have dry eye disease. And I think this is going to get younger and younger. And when you start to look at these prognostic indicators, we start to see changes in people's meibomian glands in their teenage years and early 20s. And then we start to see things happening. We get lid margin staining. Things are starting to be affected on the front surface in our 30s. And then we start to have hyperosmolarity. Now we've got cell death and apoptosis. And now we have corneal staining. And now we see things. And that's when we get tipped over into that inflammatory cascade. But those things are happening over decades. And I think it's going to be even shorter, is my hypothesis, because we're all doing things like staring at screens. And our diets are not good. So early OSD detection, that's your first hurdle, your first piece of what you're going to do in your systems. And then you're going to look for corneal staining. Just use your fluorescein dye and a Ratten filter. So job number 2 is You all have fluorescein dye in your strips. You might not have a Ratten filter unless you're doing a lot of specialty lenses. So your next job is to get one of those and put on every one of your slit lamps, so that when you do vital dye on every patient, you're going to look with that Ratten filter, because it's going to light up like this patient that I'm showing you on that left. And you're going to see a lot of things you've never seen. It's going to be super cool. And then you're going to take your little digits and you're going to push on meibomian glands, because when you push, you're going to see things either happening like toothpaste, you're going to see olive oil, or you're going to see nothing happening. And that's going to indicate that you've got non-obvious meibomian gland dysfunction. And then you're going to look at tear film, and you're going to do that with your vital dye. When you look at enough tear meniscus heights, you're going to know when it's not normal. You're going to know when it's too much, and you're going to look for things like conjunctival chalasis, or what's causing this epiphora scenario, or there's not going to be any tear meniscus, and you're going to go, this patient's not making enough tears. We're going to look at aqueous deficient issues and what's happening with the patient. So what's a good definition of dry eye disease? And I'm going to answer a couple of questions real quick. Is Bespoke Vision exclusively a practice for dry eyes? It is not. So I still see primary care patients Mondays and Tuesdays. I have built my dry eye practice around my own self-referrals from my primary care practice. And then I do get outside referrals now from MDs and ODs, which is very exciting, but that is a slower pace, and it's taken about 10 years to build that. The Ratten filter help highlight sodium fluorescein, yes, and it highlights. The reason I started using that is because lissamine green was on back order, and it's super frustrating. And so the goal of it is to see it brighter. It also will stain the conj very much like lissamine green does. The one thing that it doesn't do is, if you're worried about friction issues, you still need lissamine green. So if you've got somebody that you suspect has SLK, who has lid wiper epitheliopathy, and you really need to see that, and you think they have friction problems, then you're still going to pull out your lissamine green. But the goal of the Ratten filter and your sodium fluorescein is to highlight things that you normally can't see with fluorescein that you can see with lissamine green. And then it saves you a lot of time with the slit lamp too. So desiccating stress, when I think about my favorite definition, and I learned this from a couple of people, Don Korb is who came up with this, and then my good friend Dave Kading is really who put it kind of into practice in a way that I could understand, is desiccating stress is when the ocular surface structures fail to protect itself from desiccating stress. That's the definition of dry eye that I use. When you're sitting here and you've got a little fan blowing on you, or you haven't had enough water to drink today, you're not blinking enough, like all of those things are desiccating stress, but your whole ocular surface should not fall apart. Your body should be able to overcome that. But when you lose homeostasis in the front surface, anything new and different that is desiccating stress is going to cause a problem. And so that's the way I think about it. When I tell patients what our goal is, I'm trying to restore homeostasis to the front surface. We've lost it because of all of these things. And that picture that you see is from TFOS DUCE 2. And the gray circles on the outside are all the things that cause desiccating stress. And then you have the blue circles inside of what's really happening. So you've got tear film instability. Once you have tear film instability, then you're going to have hyperosmolarity. Hyperosmolarity, all that measures is evaporation rates. That's essentially what it measures, is the salt content of your tears. When your tears evaporate too quickly, your tears are going to be saltier, right? And so then you're going to get cell apoptosis and death, because you've got a hyperosmolar cornea. If it's hyperosmolar, it's going to be around 308, and then a difference between the two eyes of greater than 8. Those things are certainly telling us that there's a loss of homeostasis. And then we go from there, and now we have inflammation. Once you have inflammation, it's going to recruit more T cells to be activated, and you're going to continue in this very vicious cycle. So that's all that diagram means. All right, so let's continue through our journey. So we talked about symptoms already. There's multiple ways to get this. So question, on a routine exam, what's your conversation like when you diagnose dry eye? Do you start any OTC treatment? Do you wait until they come back for a dry eye evaluation? Beautiful question. So on a routine exam, and if they have a speed questionnaire like this, which they do, if it's 6 and greater, then I have standing orders to automatically do 2 lab tests and their point of care test, MMP9 and osmolarity. which I have every patient sign an ABN for those two things so that we don't have to worry about the paperwork. If they're there on a vision exam, because it's a lab test, I'm still going to run it because it goes through the lab test. I'm not worried yet about, is this a medical exam or is this a vision exam? So I do diagnose the patient at that moment in time. Yes, you have dry eye disease. This is a chronic progressive disease, and you and I need to manage it. So it honestly depends on where they are in all of those numbers. I think there is absolutely nothing wrong with bringing a patient back to do a dry eye evaluation. You have a finite amount of time in your exam lanes. And when you need to, and you have a patient that's there for a vision exam, and you need more testing, there's nothing wrong with bringing the patient back. Look, I see something, this concerns me. We need more information. We're going to bring you back for a dry eye workup where we can dive into this topic a little bit deeper and do more things. And I can figure out exactly what's going on with the surface of your eye. And then we're going to develop a plan from that. So you could absolutely do that. Because so many of my patients were doing the point of care testing, I kind of already know where they are. And it's harder for me because I am so fortunate that my schedule's booked out fairly consistently. It's harder for me to bring patients back in that way. And I do not take that for granted. So for me, it works better to diagnose on that visit and start therapy. And then they come back for a 4-week follow-up to see how they're doing with the therapy that we instigated at that point in time. But that system has taken a while to build. So, try it with bringing them back and see what works and what doesn't. Maybe you diagnose somebody, you may have to abandon the vision exam because their cornea is so trashed, you can't even get a good refraction. And so at that point, they're having symptoms and you have to do the dry eye exam at that visit. And then you're bringing them back for actually the vision visit. Wow, that was a mouthful. And so I think there's multiple ways that you can do that. I think it's just going to be up to you how you want to do that and think through what, role play that. Okay, let's see how this is going to go for patients. Talk to your team, see how you want to build that together. Super, super helpful. That's a great question. So what testing do I do differently on the follow-up? I run Inflammadry and MMP. I'm sorry. I run MMP9 and osmolarity. So on that first visit, and then I'll run it again at week 4. Once I see that Inflammadry is normalized, I will let that one drop off, but I never stop doing osmolarity. For me, because I've been doing it so long, I use that as my IOP. So if you want to see me really struggle in clinic, it's when I wouldn't have osmolarity because I feel like I'm in the dark. And it very much mimics to me how you manage a glaucoma patient. I mean, yeah, you can look at visual field and you can look at optic nerve and you can look at all the structure and the function. But without the IOP, man, that's the one thing that I can change with glaucoma, right? That's for me the same mindset I have with this. So do I still have patient get glasses, contact lens at primary care visit if I diagnose dry eyes? It depends on the patient. If they have central corneal staining, then the answer to that is no, because I'm not going to get a good refraction. How often do you have patients refuse or not book the follow-up? So here's the interesting thing where they're there for their vision exam. This all comes from how you present it. So you don't apologize for it. You don't even really give them an option. And I just tell patients, you have this, and we're going to start this therapy. I'll see you back in 4 weeks. And when we check out, they're going to make that appointment for you. It honestly sounds like simple and that I'm over thinking that, but it really is that simple. But I promise it has everything to do with the way that I present it and the body language. Because if you make apologies and if you say, well, you have this and we should start this, it's probably going to take a couple of weeks to even get any relief, and it's going to go through your medical insurance. So you're going to have to pay a specialty copay. That's probably $50. If you present things like that and you put up every roadblock known to man, that's going to be a tough sell, and it's tough to overcome that. So I really don't have patients that say, I'm not going to do that. Now, are there the one-offs? Of course there are, but probably 99% they're coming back because remember, we've connected their pain points with what they're experiencing. And remember, all of our patients want to come in to see. That's what they're there for. And when you tie this symptom that they're having of their vision fluctuates, they see better in the morning than they do in the end of the day. Those are the kinds of things you're looking for during your exam that you're going to tie that to. And when they understand what you're doing and why, they're going to come back. So if you have a lot, and granted, I think some of that has to do maybe with where I'm located as well, but that I think is a good way to start that, so that you don't start out behind the 8 ball. And then how do I bill on the follow-up? So I definitely bill medical on the follow-up. If they have medical insurance, then you can't really do a cash pay because some of these things are covered by insurance. And so that's going to depend on the region that you're in and the way that you have it set up as well. So just remember that if you're doing things cash pay, you just make sure that you have the patient sign an advanced beneficiary notice or an ABN for that. All right, so you guys are asking good questions. I love this. So we may have to have a round two. So symptoms is one of my favorite things. And one of the first things you should do, point of care testing, we just talked about osmolarity MMP9. What we're viewing here is MMP9. It's either positive or negative, just like pregnancy. Osmolarity, we've already talked about as far as what's normal, what's not normal. It creates light scatter. So those patients who say, my vision is blurry. Okay, tell me more. Is it blurry in the morning? Does it get more blurry as the day goes? Does it seem like it fluctuates throughout the day? Are there moments where you see better? Tell me more. Those are the kinds of things you're looking for, because a hyperosmolar cornea is going to have vision fluctuations. They're not going to see well because you've created light scatter. And that's all this graph is showing us. And it actually is pretty equivalent to like a grade 2 cataract, right? That's pretty blurry. So those are the kinds of things you're looking for. Tear quantity, how many tears they're making. Certainly you can do more sophisticated testing, but I like having tear meniscus height. Get really comfortable doing that on every patient, because when you see enough normals, you're going to know when it's not normal. Is osmolarity testing reimbursable? It is. You need a CLIA waiver. So it's a lab test, and it's a very simple form that you can fill out. And I think it's $75 for a 3-year certificate, somewhere in that ballpark. And then are there ABNs available for dry eye procedures? So you can just use the general one, like for a Medicare patient, you can absolutely just use that one, or you can customize it and make it your own for sure. Just the key thing is to having one. Think about the lacrimal functional unit. So we really have to remember how this all works together. It is a very sophisticated system of how the front surface stays clear and how the tears interact and how powerful that refractive surface is. So remember, there's all of these little TRPM8 receptors. They sense heat and they sense cool. And as the tears evaporate, it's a cooling effect, right? What does that tell the brain to do through those afferent signals to the brain? It says, oh, I have evaporation. My little cooling receptors are going off. I got to make more tears. And that's what happens through the lacrimal gland and the accessory glands, through the meibomian glands, and through the goblet cells. When that tear film breaks down and you have too much evaporation, or you wind up with inflammation, now that whole system gets wrecked, and that feedback loop does no longer works. So there's ways for us to really manage the LFU, and we're going to have more things probably in the future to manage the LFU. So just understand that when you trigger the LFU, you're triggering all of the pieces, because you can't pick and choose. You're going to trigger the lacrimal glands again to produce tears. You're going to trigger the goblet cells to degranulate and make mucin, the glue that everything sticks to. And then you're going to trigger your meibomian glands to express, and that nice oily meibum that's going to keep it all from evaporating. Those are your key pieces in those afferent and efferent junctions. So let me look at, we got a good question. Do you find adequate tear meniscus but abnormal phenol red testing ever? And if the tear meniscus is low, isn't the red thread testing always abnormal, and vice versa? It's a great question. So when I want a more quantitative way to measure where we are with aqueous deficiency. You can do it two ways. Phenol red is much more comfortable than Schirmer's, and so you could do that either way. But I do think for those patients that you have high suspicion that have, example, Sjogren's and an aqueous deficient disease, and a lot of times certain insurance companies want that. I work at the Oklahoma Medical Research Foundation. It has the largest Sjogren's population in the world. So in that clinic, I do Schirmer's on every single patient. And you're right, phenol red is much more comfortable than Schirmer's. So good call there. So if you see it on every patient, or you see somebody you have a suspicion, then that should trigger you to do your phenol red. Perfect thinking, like where you're going. All right, so lid structure and function, we can absolutely image all day long, and I love it for education. And so I think Mybography is a great tool and something that you could add to your clinic pretty easily to help educate patients on what you're working on and why. I just don't use it for actual functionality. I push on the glands so I know how they're functioning, because you can have an image like that one on the left that looks pretty good structurally, and you could push on those and absolutely nothing could happen. And that's going to be a patient that's going to do really well with a heat and expression procedure or working on those glands, because you have a lot to work with. The other challenge I think that happens to us is we tend to, either the patient comes in and they've lost a lot of their glands, or they're really far down in the dry eye pathway, and we're doing some things and then we get frustrated when it doesn't work the way we want it to. And that makes us lose confidence. And when we're not confident, it's hard for us to talk about with patients. But what I have found is when I intervene early, when glands look like the one on the left, but they're not functioning properly, I get really good results. And so you can use that as a tool to set expectations. You know, most of my patients are going to feel better if I get to them on the left, but if I get to them on the right, I want to manage and keep the patient from getting worse. And I'm trying to just keep us where we are. And so those are different conversations and different expectations for you and for the patient. And that is one of, I think, the biggest frustrations with managing a dry eye patient, is when your expectations are not met with the patient's expectations. And sometimes you both are in the same camp, right? And so I think that's something that this kind of tool can really help you set expectations. All right, so ocular rosacea, looking for those telangiectatic vessels crawling over the eyelids. When you start to look for these leaky vessels that shouldn't be there, and we don't fully understand why patients get this, but we know there's a lot of things. I have a whole course just on rosacea, so I don't want to take time here, but when you have those telangiectatic vessels, they're leaky, they're leaking inflammation on the front surface, and you can manage those with things like intense pulse light, trigger avoidance. We can go into more of those details, but start to look for those patients. One of my favorite questions is, when do your eyes feel worse? When you get up in the morning or as the day goes? That's going to lead you down two different paths and two different therapies. When they say, man, doc, I can barely open my eyes in the morning, I have to put drops in, or my eyelids like literally stick to the front surface, that's a patient that's got either a lid seal problem or lag ophthalmos. And you can ask the question and do this little test that Carol Blackie came up with many years ago. It's just a transilluminator. Just have the patient close their eyes, just say, just relax and close your eyes and use the transilluminator to see that light shining out the bottom, that lid seal, and you're going to manage that differently. You're going to put them in moisture chamber goggles, or you're going to put them in a tape tarsorrhaphy, or you're going to do some kind of like gel or ointment at night so that they wake up the day better, versus the patient who says, man, no, I start the day off fine. It's 4 or 5 o'clock. My eyes feel like they are just, I want to take them out and like rinse them and put them back in. That's an evaporative component to what's happening with your patients that you're going to manage differently. So look for those little pearls and those little keys as you listen to what your patients are telling you. Patient assessment. So looking at the whole face and the whole person, the way they use their eyes, super important as you're going through this. You cannot overlook the lids. The blink starts with the orbicularis oculi and our eyelids. And that is very much part of what's happening on the ocular surface. Somebody gets Botox in their crow's feet. Guess what happens? softens the orbicularis oculi. They can't blink as tight. What's going to happen? Well, that's the first stage of a blink. So as you blink and close, well, guess what? The meibomian glands aren't going to get squeezed. That muscle oryolon's not going to push the meibum out the top. So that whole little cascade of events, one simple thing like neurotoxin in the orbicularis oculi can wreck the whole system. Just like we're looking at this picture of a patient with Demodex blepharitis, have them look down, and you can see what you would miss. So that this is the same patient. And that picture on the top left is me looking at him straight ahead. And then I just had him look down. And all of those collarettes, that's on 10x. The bottom left one is 16x. Bottom right is 25x. So I still really like 10x because I can see those telangiectatic vessels. It's easy for me to miss the forest for the trees if I have my mag turned up too high. So play with your magnification, like have some fun with your slit lamps again. But I just want that's I think a good example of what a patient looks like straight ahead, looking down, 10, 16, 25x. That's how my slit lamps are. So don't overlook lids because that's a key component of what's happening on the ocular surface. For the sake of time, we're not going to go through a lot of like Demodex blepharitis. We just talked about all that. Collarettes are pathognomonic. Here's a before and after picture. Lotilaner 0.25% is what achieved this. Patient uses it twice a day for 6 weeks because the mite life cycle is about 16 days. So 6 weeks for that. This was one of the new drugs that was pulled across last year. It's actually democidal. And then I've got more images before and after. So very helpful. That evaporative component, we can now manage in a different way with perfluorohexyl octane. And if you have not heard of this, explore this. It's a very different molecule. It's not water-based, but it helps with evaporation rates. And it stays in the tear film for up to 6 hours. So it just bobs along the tear surface, buries itself in the tear film, and just bobs along the top so that your natural tear film sits underneath it. And then your tears don't evaporate as quickly. So that's something that you can add to whatever you're already doing with the patient. Or if they're naive, they've never had anything, and say it's a good computer user and they're having symptoms and their eyes feel bad towards the end of the day, that's a drop that you could absolutely reach for. It's utilized QID in the study, so 4 times a day, but investigate that one and kind of where that fits. So another sister molecule to perfluorohexyl octane is perfluorobutylpentane. So these are semi-fluorinated alkanes. They are sisters, but they don't act the same. So perfluorobutylpentane actually is a good carrier molecule. So it's carrying, and this should be, I'm sorry, this is a typo. It should be 0.1%, not 1% cyclosporin. This is a drop that's BID. So a different version of cyclosporin that we are utilizing perfluorobutylpentane to carry that highly hydrophobic molecule of cyclosporin into the target tissues. All right. Questions. Why can't we get any samples of MIBO? Great question. That's perfluorohexyl octane. So I have been informed that we might have samples come August. Right now, if you want a sample of MIBO for a commercial patient, you can prescribe it because they're going to pay $0 for it. Now, that's not going to be the case with your Medicare patients. But with your commercial patients, that first bottle is going to be $0. And then you should have samples, I've been told, sometime in August. So stay tuned for that. If a patient is reluctant to go to dermatology, how far do you go in your treatment of rosacea? Ooh, good questions. Systemic meds, topical creams, what would you do? So it depends on the patient, but if they have facial rosacea, they've been diagnosed and they know they have rosacea and they need more management of it, I am quite comfortable doing IPL. I do topical ivermectin for those patients that also have subsequent facial Demodex infestation. But I don't really get into like your topical bromonidines, your topical metronidazole, like those kinds of things, I really leave to derm. So, as I learn more, that might evolve, but that's kind of where I live right now. I don't love systemic medications to treat rosacea because I don't like to mess with gut flora. Hand in hand, when you look at the studies, we're looking at things like systemic ivermectin, which I think is crazy and messes with the liver, and it doesn't even do that good of a job when you look at the studies behind it. So I steer clear of systemic medications, and I only do topical ivermectin if the patient has Demodex facial and lids. So I leave that to my derm colleagues. It can be challenging depending on your area. It's hard to get into derm. Am I concerned about perfluorohexyl octane being a forever chemical? So I'm not, because it has no hydrocarbon that is exposed that anything can bind to it. So when you look at the molecular makeup of it, and that's different than the rest of the PFAS class. So the forever chemicals, you can bind to one of those carbons, but this is a 14 hydrocarbon back chain that is completely bound on every carbon. So there's no place for that to happen. So I'm not concerned about it. Great question. How is topical ivermectin written for OR? I'm not sure what that means. But topical ivermectin, I get through a compounding pharmacy. Does Avenova spray help rosacea? So any kind of hypochlorous spray we know has bactericidal properties. So I do utilize it for staph infections, strep infections, things where we want to keep the lid margins clean. I think it works great. I don't have any studies that says it helps rosacea, but we know in a rosacea patient that their homeostatic system has broken down. That's part of the reason why their skin has high vascular permeability, because of that. And so I think that using a hypochlorous spray in a patient that needs return to homeostasis is a good thing, but I wouldn't go as far as say it helps with rosacea, if that makes sense. What's the latest research on tea tree oil for meibomian glands? So great question. When you look at I think probably the study that you're thinking about where we had some confusion in the space is the study that came out that David Sullivan had published back in December of 2020. They looked at a very high concentration of tea tree oil in a petri dish. So it was in vitro. And they took meibomian glands, but they let them soak for a full 15 minutes. And we saw that the meibomian glands could not survive that. So when we do that topically with products that we're using, we're not soaking them, we're not leaving things on for 15 minutes at a time. So it depends on why you're using the tea tree oil. If you're using it to treat Demodex blepharitis, we also have studies that show it's not democidal. So you have to have really high concentrations that the patient really can't tolerate. But if we're using it for lid hygiene and lid margin hygiene, which we should be talking about with our patients, what's the best way to clean your eyelids? I think having a component of tea tree is helpful for lid hygiene. And I also think a hypochlorous spray also super helpful. So hopefully that kind of clears up at least that study that kind of confounded some things for us for a moment. So interventional dry eye. And we are not going to get through all these slides, but I'm okay with it because you guys are asking like really great questions. So interventional dry eye, we should be thinking about just like we do interventional glaucoma. We talk about glaucoma and how do we intervene and help patients be more compliant and help patients not be so dependent on drop therapy. And when we do this, we're thinking about heat and expression, IPL, radiofrequency, all of those things can intervene and help our patients with their dry eye. So there's multiple ways to manage that. This was a great study that was published last December, and it actually compared our gold standard of Restasis to 2 tear care treatments spread 5 months apart. And the reason they did this study was to look to see, is interventional dry eye more effective than the therapeutic, because they want to get this paid for by insurance, right? And it did prove that it was superior. So maybe this helps us get this paid for in the future. And so stay tuned, more to come, but this study was very interesting. Another question. How do I manage Demodex? So I like to manage Demodex with lotilaner 0.25%. So you would know it as Xdemvy. And I utilize that twice a day for 6 weeks. I like to actually debulk the patient in the office. So that's something that you could add to your clinic. You could do debridement. There's multiple ways to get that off. I use an okra-based extract called Ocular. I don't have any financial disclosure there, but it gets all of that gunky, waxy substance off because it takes about 7 to 10 days to get the medication that the patient's going to then use. And so I like to debulk it and then have the patient use the drops twice a day for 6 weeks. And then I bring them back at that 7-8 week mark to make sure everything's nice and clear as we want it to be. And then I have the patient come back in 3 to 4 months and we reassess. One like key component here too, as we talk about dry eye and building your practice, you're going to build in how to do your follow-ups. And so my advice would be bring them back at 4 weeks for a typical dry eye patient. For these lid patients, 8 weeks. And then once they're established and you have them managed, don't ever let them go for longer than 6 months. Think of it, build it just like you would your glaucoma patients. You would never let a glaucoma patient go longer than 6 months. Oh, Mrs. Jones, your IOP is 15 today. Great. I'll see you next year. Right? The same thing applies in your systems here. All right. So let's see. Other question. What's my process? Oh, yeah, good one. For meibomian gland expression following IPL. I don't love squeezing on cold glands. So my protocol is let's do 4 IPLs. And at the end of that, that's when I do heat and expression. And we're going to spend 15 minutes heating the lids, and then we're going to go back and express and reset things. Do I charge a debridement fee when I do debride lids? I absolutely do. Patient signs an ABN, and we charge for that service in our practice. I am also like starting to add in radio frequency between the second IPL and the third IPL. You could even do it the fourth one. So that protocol is like still being like researched. There's a lot more to come in that space. Does insurance reimburse for mammography? They do not currently. So it's a different code. I was just at AOA and I did a course together with the 2 coding experts on dry eye. So I did the dry eye part like you guys are getting right now. They did the coding part. So a lot of people have been told that you can charge external photography for mammography, and that's actually incorrect. So you can't charge. There is a code. It's 033T, I think is what the actual code is. It's not reimbursable. So that's something that you would need to consider an ABN for. I do most of my workup on a Keratograph 5M, which is an amazing piece of equipment. Well done. Find it lacking when comparing multiple reports. Ooh, for change over time. Do I have a suggestion for you? I do. I have a financial disclosure with this company, but there is a new company on the market called CSI so CSI Dry Eye. It is going to take all of your beautiful information that your Keratograph 5M covers. You're going to plug that into it, and it's going to put that algorithm and all of those things onto a lovely AI-assisted platform that you're going to be able to see that on. So CSI, and I am a KOL for them. I do consult with them. I added it to my clinic literally 4 weeks ago. But I was in the same boat as you are. I wanted that information because it's like, going through visual fields and trying to look for something. And then, oh, wait, we got GPA analysis. Yay. So that's what, to me, this is for dry eye. I've heard of RF being done over the lids without shields. What do you think of this? Is it safe? It depends on your RF. Because if you have monopolar, not safe. Bipolar, it depends on how wide your prongs are. So the way that energy transmits, it's going to be based on Ohm's law. It's halfway the distance between those 2 bipolar prongs. That's how deep it's going to go. You never are going to use metal shields ever, because you're going to spark, right? It's going to chase metal. So if you're going to use a shield, it's got to be a plastic one. So it depends on your device and how deep that energy is going. Do I image the upper meibomian glands? Yes, only in patients that have lost all of their inferior glands. There's a really cool little device called the Myverter that you can utilize to really easily flip upper lids and take great pictures. I don't have any financial disclosure with that company. So I don't image consistently, only if they've lost all glands. What's my protocol for before and afters? photos, 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 always get a consistent place in your office that you can take photos. I have a black curtain hung behind the exam room door where I do all of my procedures, and we take all of our photos there so that they're consistent. Do I compare telangiectatic and MGs before and after IPL? I don't compare telangiectatic vessels because that's not your definition of success with patients. Meibomian glands also, I don't think is definition for success. And I realize we only have 4 more minutes and closing because my biography is imperfect. So that infrared light only goes so deep in the tissue. Maybe that gland you couldn't see because it was a little bit deeper. And maybe with health things, and as you decrease inflammation, now it becomes more superficial and now you can image it and you can see it. So until we have OCT for meibomian glands, I don't use that as a marker of success for before and afters. But I absolutely utilize symptoms, osmolarity, MMP9, corneal tear breakup time, and staining. So I like to look at really objective things that I have great confidence in, and we just don't have a way to measure telangiectatic vessels or meibomian glands that I have enough confidence in at this point in time. Someday we will absolutely have it. I just don't think we're there yet. Okay, I'm going to do one more question because I want to make sure you guys get to your, maybe 2. Have I ever used Ithera shields for monopolar RF, or another shield you recommend for monopolar? So there's plastic shields that you could absolutely use. There's one that Ed Jacoma, he's an MD back east, that he has like this little device that you can put it in, and you can actually do like expression with it. It's kind of slick. So look up Ed Jacoma and those monopolar RF shields. I've had some corneal epithelial sloughing following RF to the lids with shields. So it depends on, with shields, make sure you're using some kind of like thicker gel. So obviously you're putting proparacaine in, and then a lot of thicker gel, like a refresh liquid gel, something that's thick, that kind of creates a barrier. And then the other thing is, if you have any gel on the face and it gets drug underneath that, you're going to have epithelial sloughing. So just be wary of all those things. That could have been why. ABN is advanced beneficiary notice. That's what you're going to give to patients to sign that this is not covered by their insurance and they're responsible. Where can patients get XDEMVY? There's 4 different pharmacies. Get with your local, I would go like on the website, see if you can find like your local rep. I have one pharmacy that I use but it's a local pharmacy. It's Community Care. It's a Walgreens-based national pharmacy, but Community Care is where I get the best results of getting that pulled across for patients. Contact info for CSI for the K5 comparisons. If you look up CSI, her name is Trudy, so maybe I could give it to our WU team and they could pass that out. What's the medicine for Demodex? It's called XDEMVY. When doing IPL, do I use corneal shields? Absolutely. I like to treat on the lids. Now, if you're just joining IPL family, congratulations, but use your sticky shields until you get real confident and then add in your corneal shields. Now that I have done it I've been doing IPL for 8 or 9 years at this point. So I like to do it on every single patient. And I do use corneal shields. I do proparacaine, refresh liquid gel underneath the shields. That way we have that nice cushion, but I don't like to leave those in for very long. And that's why I don't like to do it on patients that, when I was new, because I was leaving those corneal shields in for too long. And I don't like to do that. So when you get a little speedier, you're super confident, you've got your systems down, then add your corneal shields.